Welcome back. I think we're going to get started now. We're midway through the morning. A couple of reminders. Number one, don't forget to scan the QR code if you want to ask any questions to our legislators on Sunday. Number two, don't forget to sign into the meeting today so you get CME credit. Now we've reached one of my favorite parts of the conference, the Luella Klein Lectureship. Dr. Luella Klein was a lifelong advocate for women, their babies, and providers who care for them in Georgia. In 2018, the GOGS Foundation established this lectureship to honor her incredible contributions. Dr. Klein's remarkable career began with her graduating summa cum laude from the University of Iowa and earning her medical degree in 1949. She made history as the first female department chair at Emory School of Medicine and was a pioneer in maternal fetal medicine. Her work continues to inspire us to this day. I know many of you in the room had the opportunity to work with Dr. Klein. Dr. Luella Klein has numerous other accolades, including being the first female president of the American College of Obstetricians and Gynecologists and the 25th president of the Georgia OBGyn Society. In recognition of her work, we've invited Dr. Lee Padove to speak with us today. Dr. Padove is a physician at Northside Hospital in Atlanta, Georgia, specializing in diagnostic heart catheterizations, transesophageal echocardiography, stress echocardiography, temporary pacemaker placement, and other diagnostic procedures. I think we all know him best as being an advocate for our women in pregnancy. He holds a Bachelor of Science from the University of Georgia and a Doctorate of Medicine from the Medical College of Georgia. He completed both his internal medicine residency and cardiology fellowship at Brooke Army Medical Center. I will not hold that against you. Go Navy. Dr. Padove is an active researcher, author, and has served in various leadership roles. He also puts on a conference. I believe it's once every 2 years. This year it's going to be February 28th through March 1st. It's called Heart of the Matter, which focuses on cardiovascular disease in women. And he usually has Dr. El-Kayem from California and Dr. Hamid from California come out and help run that conference with him. So we're looking forward to hearing your lecture. Dr. Lee Padove is going to speak on the prevention of cardiac morbidity and mortality, the obstetrician's role. You too can be a preventative cardiologist, part one.
Thank you so much. Let's see.
The green arrow.
There we go. All right, first thing, I'm going to go back just a little bit. I want to thank everyone for having me. I'm enjoying the sites. Disclosures, unfortunately, I don't have anything financially beneficial to this discussion. What we're going to do is, let me first thing say, I'm a fellow American College of Cardiology. And, my initial thoughts was I need to explain why I'm here. And then after getting here for 12 hours, I decided I need to actually advocate to get invited back next year. So anyway, so some of my objectives of this is, one is to convince you why it's important to know cardiology, and also to understand the cardiovascular risk in the rising maternal mortality and how we can identify patients that are high risk, why it happens, who it happens to, and how can we prevent that from happening. So my talk is in two parts. If anybody's seen Horizon, the first part, I enjoyed it. They're going to have two parts, so I guess I'm sort of making myself Kevin Costner. All right, so we're going to discuss mainly today about preconception and pregnancy. All right, so we were talking out in the hallway about the anxiety. There's anxiety that the cardiologist has when an OB patient walks in the door. There's anxiety when a cardiac patient walks in the OB's door or has symptoms. So think of pregnancy, and oftentimes it's thought of as a stress test of nature, right? The heart's pumping harder, the body's being stretched. It's not like a stress test that we do in a cardiac office where you get on, we max you out, you get off. You don't have that choice in pregnancy, right? And you're there for the duration, hopefully. So why is there anxiety for cardiologists? First thing is, anybody here seen Gone with the Wind? Okay, so Gone with the Wind, one of the favorite scenes, don't know much about birth and no babies. Cardiologists don't know much about birth and no babies, okay? for the most part, there's not been much information, because think about our days. Most of research nowadays is geared by pharmaceutical companies, research devices, and who are the patients that you're not going to test on? It's the pregnant patients. So there's not money in research for new drugs, new procedures. And the other reason cardiologists sort of diverted the pregnant patients is they were pretty friggin' busy, so they didn't want to see somebody they didn't feel comfortable with. So it makes sense why the cardiologist doesn't want to see a pregnant patient. Obstetricians, number one cause of death in pregnancy, and we'll go over that over and over again, is the heart. So you don't like heart patients, right? That scares you. On top of that, you're taking care of two, and you don't like the idea that one of them starts out causing problems. So in the general population, look at the top. This is during the COVID era, 2019, 2021. See if I got, nope, didn't do it right. There we go. Look at that top line. What is that? That's heart disease, more than all cancers put together. And this is in the era of COVID, right? The year that we heard all that about COVID. So in general population, the number one killer is the heart, right? And then if you look at pregnancy-related deaths, if you look right here, cardiomyopathy, cardiovascular, coronary diseases, 26%, more than than any other. And we could sort of include eclampsia and preeclampsia in our bailiwick, and even embolism. So that's why cardiologists should be more involved. That's why we are important. That's why if you have another talk here, I'm happy to come back, okay? All right, and then one other thing to look at is, and we sort of mentioned this earlier, preeclampsia also increases or is associated with increased risk of early cardiovascular disease. The worse the preeclampsia, severe preeclampsia, 6 to 8-fold increase of premature heart disease, 2-fold in all preeclampsia put together. So very, very important, and that's why I'm here, okay? Now, let's talk about what happens during pregnancy, and this may explain some of the stuff that Dr. Pena was talking about earlier. So I'm gonna walk over here and make y'all look at this one slide. So on the bottom, pre-gestation, first trimester, second trimester, third, delivery, and then early postpartum. To get you the lines, right there is cardiac output up on top. It goes up during pregnancy significantly. So the heart pumps out more blood, right? How does the heart pump out more blood? Partly due to heart rate. So you increase the heart rate, pump more blood out. What about systemic vascular resistance? It goes down, meaning that there's less that the heart has to push against. And going back to Dr. Pena's lecture, early on, blood pressure usually goes down and then comes back up. So if you've got high blood, this is my thoughts of why 20 weeks, if you have hypertension, that since it should go lower, then it's probably saying, hey, we've just found somebody that's probably been high blood pressure before now. All right, this is my simplistic whoops, I keep getting carried away. Y'all can't take me anywhere. All right, so think of the body as this stream, right? You got flow of the stream, all right? Cardiac output, we already talked about. You didn't know we were doing physiology today. You're going back to nursing school, medical school, whatever school. Cardiac output, heart rate times stroke volume. Something that impedes the stroke volume is bad during pregnancy, because remember what we said, there's more cardiac output. So high risk of stroke volumes impedimented, or whatever. English is a second language, sorry. All right, pre-pregnancy evaluation, that's the things we're looking for. So here's some simplistic. Again, decreased systemic vascular resistance, vasodilation, increased cardiac output. Well, what things get in the way of that, right? The heart's got to do that. Valve stenosis. Stenosis meaning the valves don't open up very well. It's obstructed. It's not able to increase the cardiac output, especially left-sided more than right-sided, okay? What about increased vascular resistance? The classic one is pulmonary hypertension that until recently was a forbidden thing during pregnancy, and there's Diane Zawicki has some information with severe pulmonary hypertension with amazing success rates, so maybe it's not, but again, in the past, or untreated pulmonary hypertension was a bad thing. What about heart dysfunction? You'll see, and we'll go over some of the different algorithms and so on. Used to be less than 40%, now they say less than 30%, but less than 40% if you're functionally impeded. Intracardiac shunts, significant shunts, doesn't allow the blood to increase out to the periphery. And regurgitation, that's leakiness. Leakiness of the valves are usually better handled than stenosis, because what happens during pregnancy again? Systemic vascular resistance goes down, which allows for more blood forward, not as much coming backwards. If you could make a drug, in fact, years ago there was a trial that they tried to get off the ground that was basically a synthetic relaxant that they tried to use for regurgitation. Unfortunately, it didn't make it through the safety part. So this is just going back over what we were just talking about. Again, cardiac output, that's the thing. It's got to increase. Blood pressure usually goes down the first 2 trimesters, and that's something for you as the general OB to think about when someone comes in is if their blood pressure is this at 12 weeks, what's it going to be at 28 weeks? And that's a common time that when I'm seeing patients, I'll say, come back at 26 weeks or something like that. Heart rate, we talked about, usually increases. Very seldom do you have heart rate impediment in the young patients, but it can happen. And again, we talked about the normal response is systemic vascular resistance to go down. So with that, you can figure a lot of the things that go bad, right? And there are different times that, during pregnancy, potential places in pregnancy to prevent early cardiovascular death. And it goes all the way from pre-pregnancy all the way to postpartum. So don't forget the pre and don't forget the post. And I'll explain to you later, that's actually the 2 most important places, right? Lots of times it's selection. It's the women that shouldn't get pregnant that give you the most heartburn, especially for those of us that are the specialists in there. All right, so again, how can we reduce? Identifying those at risk, reducing the risk of the diseases they have, and reducing the endpoint problems. All right, so how can we change maternal mortality? All right, first thing is learn how to identify those at highest risk. I gave you the physiology of what makes you think about certain people high risk, right? Just then, all makes sense when you think about it the way I presented it. Can't get enough output, it ain't good, for the mom or the baby. So preconception, which we've sort of alluded to, very, very important to talk about birth control at that time. Who shouldn't get pregnant? Or identify those that need a higher level of care when they do get pregnant and let them know what to expect. Let them know if maybe your local hospital can't handle their needs. Let them know that it's not all fix up the baby's room and all that stuff, that there's certain risk. And if they're at high risk, we'll talk about over and over again, but one of the catchphrases is teams now. Teams made up of the MFMs, the cardiologists, the anesthesiologists, and even other things like social workers and things like that. If you look at during pregnancy, that's the time when most of the OBs identify things, is all of a sudden they're stuck with a woman that they didn't even think about getting pregnant because she picked a time that they didn't expect or hadn't been to see them in 2 years. And all of a sudden they're at high risk. So identifying them, knowing when they need escalation of care, again, getting teams involved, and even delivery at time. We talk about care plans and high risk now in our notes. It's easy to find our notes, but what I'd like to do with at Northside is actually get one place that you can look for all that rather than having to scroll through 300 documents, which is what happens now. All right, so I'm going to talk about, I'm jumping around because, flight of ideas, a little ADD in me or whatever. Any psychiatrists here? I may be in trouble. It's okay. So this is a case that's dear to my heart, and I saw Ann Patterson here earlier. Ann, are you still here? Okay, I think you and I got involved in this case. Do you remember somebody, she was mid-30s, upper 30s, had quadruplets. The day of delivery, or day after delivery, she suddenly had sudden onset, chest tightness, shortness of breath, tachycardia. Back then, ventilation perfusion scans were the scans of choice. Everybody's thinking hypercoagulable, shortness of breath, hey, it's got a PE. Her VQ was negative, which was about the time I got the emergency consult. I remember strolling on in, or not strolling, being rolled on in. If she was strolling, that would have been better. She had a negative VQ. I actually went to the cath lab. Now, I will correct a little bit about my biography. I gave up cathing for Lent about 10 years ago. I wasn't doing as many. Pregnant patients don't need caths very often. I'm not an interventionalist. That was going by the wayside. So I don't stick needles in people's legs anymore. Not even for fun. What the hell? So anyway, went to the cath lab. And at that time, when you injected contrast into the arteries, we had what was called CME. And you had a playback in the cath lab that was like archaic. You couldn't see crap. And that was what we were making our choices on. And at the time, I saw her proximal LAD, to remind you anatomy, on the left side of the heart, left main coronary artery is the root of the tree. That's bad stuff when that gets blocked. Right up against it is the left anterior descending, which supplies most of the blood to the front side of the heart. She had a severe blockage right there at the beginning of the artery. And I did what I thought was smart. I put thrombolytic therapy down there. I thought it was smart, and you'll see that maybe I wasn't. But it opened up, and she ended up getting surgery like 3 or 4 days later when she had recurrent symptoms. When the CME came out, which was the high quality, about 20 minutes later, you could see this classic picture of what is called a helmet. That's where the artery has basically dissected, and you see the contrast going up, and it looks like a helmet. And all of a sudden, and I had done at that time, I'd probably done about 2,000 or 3,000 casts in my life, and I'd never seen anything like that. So that's what we knew. That was mid-90s, right? Remember what I said earlier is we didn't know much, okay? Whoops, I keep pressing the wrong thing. Of course, I'm the only one using the pointer. If anybody gets me mad, I'm going to blind you. All right, this is from 2014, Dr. El Qayyum, who got misspelled down there, but who's going to be at our conference, who's probably the father of cardio-obstetrics, wrote this paper. About the time I'm through with the talk, I'll get this down. So if you look, this is divided into different etiologies, and this was, he sent out questionnaires to cardiologists, and he said, okay, how about your heart attacks? Tell me what you saw. So it's not like a control lab, and some of this stuff is hard to tell the difference. But if you look right here, coronary artery dissection, which I told you that was the first one I'd seen in 3,000 casts, it's the most common cause of heart attack in pregnancy. We'll talk about what that is. And it most often occurs third trimester or postpartum. And it makes up about 43% from this database, okay? So that's coronary artery dissection. Atherosclerosis, which we tend to think of, which is the traditional risk factors, only made up 27%, and that was usually earlier than later. Clot, remember hypercoagulability, normal arteries, that still happens. Spasm, rarely, and Takotsubo's. And realize that this database has some faults to it, because it's the opinion of the center, not a central center grading it. All right, so SCAD, spontaneous coronary artery dissection. What did we say? High percentage late pregnancy, early postpartum, associated with older and IVF. And I didn't say IVF caused it. I said associated. That's one of the big arguments with IVF. Does it cause things, or is it a sicker, older group, all that stuff. So it's oftentimes harder to look at the literature. This is actually a picture of what happens. So if you look, that's a normal artery. What happens is in the lining, there gets to be a dissection, and it can propagate, and in fact, it can increase. And usually the way it heals is a blood clot. So remember, I gave thrombolytic therapy, and she actually did better. Sometimes it's better to be lucky than smart. But I will defend myself in that this stuff that I'm showing you here wasn't known at that time. But it does stick in my mind right now, I'll tell you that. Of course, that was the only time I ever did anything wrong, so it does stick in my mind. So acute MI, the things I'll just show you is the traditional risk factors are way down here. It's more associated with age, maybe also associated some with other things. So just to show you, this is a summary paper here from Key Park. And It talks about presentation. All right, our patient, you won't be able to forget this. Postpartum, she came 2 days post, left anterior descending, yep, that was us. Now, she didn't have multivessel. Careful angiography, because remember what's happening is the lining of the arteries are friable. And when we stick a catheter, we're sticking a little tube down there. And if it's already friable, you can cause problems. And those aren't good problems because, remember what I said, the root of the tree is the left main. That's the first artery we're sticking a tube down. Look at this treatment. Conservative treatment is, and this is where, again, pregnancy is different. If the patient, even if they have ST elevation, if they're hemodynamically stable, if there's good flow, you leave it alone, let it heal. Intravenous heparin should be discontinued because remember the clot is good. And what is it? God, geez, what is this right here? It says thrombolytics should be, or contraindicated. Whoa, I did the wrong thing. Got lucky. Invasive management is really only for instability at that point. And then here, this comes up because, this is the faults of, again, I want to say, what is happening with a lot of the cardiac pregnancy literature is it's show and tell initially. And the first show and tell of SCAD was patients that got pregnant again, about 20% of them had recurrent SCAD. That was because it was show and tell. It's what people think about. Oh, I had a patient, she had this happen before, and now it's happening again. It looks like the numbers are going to be lower, but we still worry about it. So we're not quite at saying, hey, we can't counsel you. We can just say that it is felt to be increased risk. We don't know how much. Initially, we said, don't get pregnant again because bad things can happen. I still like them not to get pregnant, to be honest with you. That's my heartburn, though. All right, so this is serious cardiac events in women with heart disease. With heart disease, okay? Preventable versus not preventable, because what we want to know about is what is preventable. That's the emphasis of me being here. And if you look, the blue is significant among many places within it. And this is women with known heart disease. All right, this is an important slide because it's talking about the team approach. And that's where we're headed towards, because pregnancy is not just the OBs here, the MFMs here, but the anesthesiologist, the cardiologist, the intensivist, whoever else needs to be involved. Primary care, you've already mentioned. So that's the team. Now, this is sort of nice, and we'll go through some of this. It talks about preconception, contraception advice, optimized medical status, look at medicines like Juan was talking about, look and see which ones can be used, which ones shouldn't be used in pregnancy. Sometimes we've done some cardiomyopathies that resolved, and then we have to take them off of the medicines. They can't be on an ACE or an ARB or an ARNI. Shouldn't be on spironolactone during pregnancy, although that's a questionable thing. We don't do it. So, that's that initial part is trying to figure out what we can do to make y'all seize, what we can do to identify those at risk. We'll talk about some of the risk stratifications. During the pregnancy, again, serial monitoring, delivery planning, balancing maternal and fetal risk, labor and delivery, we'll talk a little bit about. Postpartum, we sort of talked a little bit about that. You'll get a talk about the 4th trimester later, and long-term, we sort of mentioned already the increased risk for in the future. Oh, I didn't start my timer, so, oh, there's one, good. All right, so identification of those who are at high risk. So we talked about disease or anatomy related. I gave you the little physiology so you can sort of figure those things out. Functional status is real important. So the functional status before they get pregnant often tells you a lot. And I'll ask them, can they do 2 flights of stairs without stopping? Do people have to slow down for them? Because lots of times people, if you say, can you do 2 flights of stairs? Oh, sure. And then you ask them if they stop. Yeah, twice. That's a little bit different than being the first one up. The other things are genetic diseases, and this is where you take family history, and people don't realize how important that is. Family history of sudden death, aortic disease, hypertrophic cardiomyopathy, prolonged QT, Marfan's, also looking at for elongated fingers and things like that. Age, we'll go over and over again, is a big mortality factor. And IVF is associated, but again, when I say associated, I don't want to get things thrown at me. I want to make it clear they're also seeing older patients sometimes, sometimes people with more than one problem. So it's an association, not a cause and effect. All right, this is back to the, women with known heart disease. So I'm going to drive y'all up the wall with that. So this is the whole group. 3.9% had serious cardiac events, life-threatening or lost their life. And then when they looked at those patients, what you'll see is a lot of it was either were preventable. About 50% of that population is preventable. And that's what we're talking about here. What can we prevent? Because I like to use the S word, but instead I'll say crap happens even when you're doing things right. You want to prevent everything you can. So if you look at provider management related, there's several different ways that we can do things with the provider management. First thing is failure to identify a condition before pregnancy. So those were ones that we didn't identify the risk. Failure to identify high risk. So again, that's what you want to be able to do. Late recognition in cardiac deterioration. Delay in diagnosis and treatment. Inappropriate treatment. And also, one of the big things, what we were talking about, no preconception counseling, because the woman should know ahead of time what's her risk. I'm not saying don't get pregnant. There are some that you say don't get pregnant. I started to slip in a slide that I had in a talk from 20 years ago. My 35-year-old daughter would kill me. It was when she was 15 years old, and I had what I thought was a funny slide. She didn't. Which had a picture of her, and I said, as a subtitle heading, who shouldn't get pregnant? My 15-year-old daughter, you know. So, but we're talking about medically, all right? Let's keep on focus there. So again, over and over again, maternity and mortality, opportunity to identify cardiovascular risk and death. So identifying the risk, whether it's before pregnancy, after pregnancy, or whatever. As we know that there is a high instance of surprises. Surprise is great if it's a gift, not if it's a pregnancy, like a high-risk pregnancy. And what this slide does is shows you unintended pregnancy rate per 1,000. Even in 2011, it's still pretty high up there. And then I want you to look at the different age groups, because over 35, there's some surprises. Obviously, the young, but you would think over 35, there shouldn't be too many surprises about getting pregnant. Certainly not in the 30 to 34s. But, you know, in that group, it's flat all these years. So that's a little bit of interest. So, you know, the reason why I brought that up in my own little crooked mind is to remind you that you need to talk, you as OBGYNs, you need to talk every person. What I was taught to do is I'll ask them about contraception, and they'll say, well, I ask them if they're planning pregnancy, and they'll say, oh, no. And then I'll ask them, well, what are you using for contraception? And if they say they're not, I say, well, you're planning pregnancy. I don't know who taught me that, but I think that's cute. I hadn't gotten slapped yet. All right, so risk stratification models. I sort of mentioned this earlier, and I'll just sort of go historically for you. Cariac was from Montreal, from Toronto, not Montreal, somewhere up north, colder than here. Goes back to about 20 years ago, and it's a very simple risk stratification model that showed cardiac event rate. The more of the risk that they had, the more likely they would have one of these problems. And they went back and did it prospectively after retrospectively and even validated it. And what the risk factors were prior cardiac events such as heart failure, stroke, TIAs, or arrhythmia. Baseline New York Heart Association classification of 2 or greater than 2, meaning that they get tired at normal activity or worse. Cyanosis. Then we remember what we talked about on that slide of the river with flow. Stenotic valves, valves that don't open up well, is bad. And that's what this shows. Left heart obstruction, mitral valve area less than 2, that's only moderate. Aortic valve area less than 1.5, and that's only moderate stenosis, was bad. Hypertrophic cardiomyopathy causes an obstruction to flow. Muscle gets in the way of the flow. 30-millimeter gradient at that time was bad. Now, there's more to this than that. It does identify high risk. These are not necessarily groups that I wouldn't say could get pregnant now, but it's people that need attention. And then, of course, we've already talked about reduced ejection fraction. That means the heart's weaker, and it makes sense. It's not able to augment and increase the cardiac output. So that's going back to that physiology slide that I think everybody's going to have down pat by the end of today. Now, the CarePreg did not cover certain key areas that are extremely high risk. Prior mechanical valves and history of prior peripartum cardiomyopathy. And then the other thing is high-risk aortopathies. That's the bicuspid valves is on, you have normal aortas, bicuspid aortopathy, that's the valve problem, bicuspid, you're born with congenital, 50% of them or so, give or take, will have aortopathy, a problem with their aorta made up of different materials, which is not as bad as Marfan's and Lloyd-Dietz, but is still something that isn't in that predictive model. All right, I did find this old slide. So if you look, here's the mom walking them across a grate, and maybe we should identify those who shouldn't be a mother, okay? That duck was for different reasons than that, okay? All right, so we have risk stratification. I just told you about CarePreg, which was the, since we're in a pregnancy, the mother of all risk stratifications. In addition, there was Zahari that has been done. We're going to look at the modified World Health Organization because that tells you a lot of things. That was done in 2018 I think was when it was published in the American Society of Cardiology. It's lesion specific. It identified those who were class 4 shouldn't get pregnant, and some of those now probably can, and those who need a higher level of care. So it's at least a guidance. It didn't sit there and just say bad or not bad. It even said maybe this should be at a tertiary hospital versus not. And that should be also part of the counseling, that when you think about it, if you live in a small town that's 150 miles from the tertiary hospital, the mom should know that. And CarePreg worked off of CarePreg 1, CarePreg 2. All right, so this was combining CarePreg and World Health Organization. And what you'll see is the percentage of pregnancies that had cardiac events. And you put those together, and it's actually even more beneficial. But if you look at CarePreg scores are in the deep blue. And remember, we said that CarePreg helped predict and more the number, World Health Organization, so on. So putting them together is a reasonable thing. It gets hard to do, though. This right here, I'm going to walk through a little bit. This is the World Health Organization from 2020, actually, was the publication. So who won is the easy ones, all right? Those are the ones that should fly, can fly at a local hospital, whatever. Those are small shunts, mild mitral regurgitation, mild pulmonary stenosis, not bad, prior repairs of defects. And it's interesting, I'll tell you about a patient in just a second if we have time. And it talks about follow-up during pregnancy once or twice in the local hospital and can be delivered in a local hospital. Then you go up and you start talking about unrepaired ASDs, VSDs, repaired tetralogies, Turner syndromes, still can be local hospital, but need to be seen every trimester by the cardiologist. You step up more, and you're starting to say an expert center should see them. And that includes Marfan's without aortic dilatation. That includes ejection fractions that are normal but have, or close to normal, but have mild impairment. You have World Health 3 is severe asymptomatic aortic stenosis. Remember, that's that valve not opening up well. Moderate aortic dilatation, prior Fontans, things like that. Here's the level that should not get pregnant. Pulmonary artery hypertension, except for in a few centers now can do that, but that's a very specialized. That's not just tertiary, that is specialized of tertiary. And severe aortic dilatation, things like that, LV dysfunction, class 3 symptoms, things like that are not good for pregnancy. And this is more the same, this up here. And this is sort of going through that same line of thinking, patient history helping you identify, again, that functional status, prior events, no cardiac interventions, and basically coming in already sick and still sick. cyanosis, mechanical valves we talked about, coronary artery disease. I've had a few patients that had stable coronary artery disease, did fine, but I had one that we had a rough time. The high-risk aortopathy, we talked about imaging, and here's what's interesting. One of the things that this group, by looking at the records, identified, and this is in patients with known cardiac disease, late first antenatal visit. So that in itself was a risk factor for bad outcomes. So access to care is also in there. And this is yet another format, and this of looking at the same stuff. I'm trying to cover like, nowadays fellows are now going to be in cardiology, now supposed to spend 3 months doing this stuff. So we're doing this in, 45 minutes? There'll be a test afterwards, okay? All right, but this is nice. This is, whoops, I did it again to you. This is, again, Dr. El-Kayem wrote in this. Basically, it's different valve disease, complex congenital, pulmonary hypertension, aortopathy. It tells you about pregnancy management. It tells you about delivery. Now, what I'll summarize delivery is, for the most part, if they're clinically stable, my role as a cardiologist is to say, I'd rather you vaginally deliver, okay? I'd rather they get delivered vaginally, not as much fluid shifts, mom handles it well, you don't have late complications. There are some exceptions if they have a severely dilated aorta, if they're hemodynamically unstable. Those are things where I'm going to say, from my standpoint, hey, I want you to do a C-section, get that baby. I do it as a concept. If the baby's so sick or the mom's so sick, you need to separate the two so you can take care of them separately. And so if the mom's so sick that, hey, I need to do a lot of stuff, then that's when it comes in play. But very seldom am I going to tell a patient C-section. So if they come back to you, Gretchen, and they said that I said a C-section, say, no, I don't think you did. All right, so here's one other thing. Let's identify the risk. And here's a slide that most of you have seen. And what you'll see is this is mainly first world countries. And what you'll see in the middle is the US, and the orange is the 2008. And of the first world countries, we were the only country going the wrong direction. And I'm plugging our conference because I showed you some slides from Dr. El-Kayem. Dr. Hamid was very, very involved in the California Maternal Quality Care Collaborative, CMQCC. And what you'll see is, there we go. What you'll see is this is a slide showing both the United States and California. And what you see is right around 2006, California had looked backwards and said, hey, we're not doing so well, and the whole country wasn't doing well because we've already talked about the increasing mortality. But look what happened here. And they started implementing various toolkits, whether it's bleeding toolkits, whether it's preeclampsia and later on cardiac. So they've made a big change in what they do. And our knowledge base, and a lot of us, including this state, trying to copy that. The other thing that's important to notice, look at when the diagnosis was made. Either at the postpartum period or even worse, postmortem period is where a majority of diagnosis. So remember what I said earlier, one of the roles we have to do is look early, look hard, try to identify patients before they get pregnant, let them know what kind of care they need. A lot of it's a selection bias in the death there. And in their toolkit, they had various red flags, and I think I got this multiple times. This may have been the initial version. But, basically it's, I'm going to pull you forward just a little bit. Now, I think I got overzealous with cutting out slides last night. So basically, there's symptoms, signs, and findings, okay? Symptoms include shortness of breath, orthopnea, PND. Findings that require extra care include a heart rate. Tachycardia should always be evaluated and an answer figured out. If you see a tachycardia greater than 110, you should be asking yourself, why is that there? I need to be able to explain it. Do I need the help of my MFM? Do I need the help of primary care? Do I need the help of the cardiologist? Oxygen saturation, this is the original data toolbox that they had. It's changed, was 94% or less. So one of the problems that you have out there and I don't mean you as an individual, but you as a physician, provider, caring for patients, is what is one of the most common complaints a pregnant woman has? I'm short of breath, right? I think that the literature is like 2/3 of women pregnant will complain of shortness of breath. How do you decide when that's something that's bad? Some of the things that we do in our office is we actually have oximetries. We have a walk around. We look at what their resting O2 sat is. We walk them for 6 minutes. If we see it drop by more than 5% or less than 90, then all of a sudden that needs better care, more prudence. Also, what may be helpful for y'all is to use what's called a BNP. Does everyone know what a BNP is now? And there was a time when I used to give lectures to OBs, and they said, you mean metabolic panel? No, B natriuretic panel, or pro-BNP. And it can be helpful because it goes up a little bit in pregnancy, but it shouldn't be abnormal. The other thing is when I take a history of someone pregnant who says they're short of breath, I'll do a short-term history of the last few days, because what I find is one day the woman is able to walk up the stairs, has the nesting instinct, is making room for the new kid, and the next day they say they're short of breath saying a sentence. Shortness of breath of pathology is usually going to be persistent. It's not going to come and go in that kind of short time. And then we talked about our oxygen levels, checking that in the room. This is actually pro-BNPs here. And what you'll see, a little complicated, but basically what you're looking down here is not pregnant, normals, whether you see it pregnant, first trimester, second trimester, third trimester, 100's a pretty reliable number, even though it's a little bit shifted to the right during pregnancy. The other place where BNP helps me sometimes is when we were talking about patients hard to control blood pressure postpartum. If their BNP is high normal and they're about to get MAG and their blood pressure is hard to control, sometimes I'll give them some Lasix along with potassium, try to stay ahead. So those are the patients that sometimes the hard to control blood pressures are volume related, and I'll give 2 or 3 doses of Lasix. Dr. Pena and I were talking about even looking at JVP. Sometimes people ask me what the hell am I looking at, but I was saying jewelry looks nice. What about palpitations? Okay, so I'm trying to give you some helpful hints. Majority of palpitations in pregnancy are benign. What's interesting is there was a study about 30 years ago where they put monitors on pregnant patients who had palpitations, and they actually had more ectopy, more PVCs, more PACs, but the ectopy usually didn't correlate with when they had their symptoms. So it's something to know. So when should you be concerned? Okay, I will say this over and over again. Family history is helpful, okay? Family history of sudden death in anybody, first cousin, second cousin, third cousin, at a young age, under the age of 40, may tell you about cardiac arrhythmia, like long QT. Also ask if there's been early drowning in anybody, because with long QT, if they get in a cold water, it'll cause an arrest. Any kind of prior cardiovascular disease, especially with prior arrhythmia history, again, that sort of means send them to the cardiology. If they have palpitations associated with passing out, that's also another thing. And then I was looking for a neat slide I had somewhere, but I couldn't find it, where I had a picture in OB land, is what I call when we go down to the many areas of OB, where it was the mom's heart rate was on a monitor, the old-fashioned way that they used to monitor that. And what you saw was she had recurrent SVT, supraventricular tachycardia. And what you would see is the heart rate was like this, and it was like a box would go up and then do this and go back down. So sudden onset, like boom, like a light switch, is more than likely a reentrant tachycardia, which is the most common type of tachycardias. All right, so what I'm going to tell you is risk does not end at delivery. This is to help give a segue till tomorrow's talk, so you'll come back, and then maybe I'll get invited to another conference, which is the real emphasis. So timing of death, okay? Look at that, 44% of hemorrhage occurred within 24 hours postpartum, 69 occurred. This is from the Georgia Public Health, by the way, our mortality data from 2018 to 2020, I believe. So the mortality related to hemorrhage, 44% occurred within 24 hours postpartum, 69% occurred within 7 days. So you're at the finish line, you thought, but you're not. Mental health conditions, which is a rising cause of problems and death, 87% occurred in the postpartum period. Cardiomyopathy, majority of them were actually identified more than 6 weeks out. And then if you look at other cardiovascular conditions, about 70% occurred in the postpartum period. So you're not through when the baby comes out, is what I'm trying to tell you. And again, this is, again, from the Georgia data. If you look at this, 23% of the ones that died in 2018 to 2020, with professionals reviewing it, 23% had a good chance of being prevented, and 78% had some chance. So that's why I'm here giving a talk, right? If it's going to happen, it's going to happen, then get someone else up here to give a talk. And I think the bottom line is cardiovascular death is largely preventable. We've learned a lot. I kiddingly say that I used to know all the literature on the back of my hand. Then I had all the literature on a thumb drive when you used to call them thumb drives back about 20 years ago. There's literature coming out on cardiovascular, cardioobstetrics every day. There's multiple articles every month. Used to be a few articles a year. There's, like I said, American College of Cardiology now has a subsection on cardiovascular health and pregnancy. They have recommendations for formal training rather than you got to learn it on your own. And also, you know, we talked about team-based, and you know, the other thing is don't let your guard down because it happens after delivery too. And again, that's the team-based stuff right there that we looked at earlier. Thought I had a slide in to plug what we talked about before. We do have every other year Heart of the Matter conference in Atlanta. We've had probably 8 or 9 of them over about 15 years. We initially did it yearly, then we didn't do it for a few years because I was owned by another hospital system. Even though I still did consults, I didn't want to do it at another hospital. Then when I came back, part of my contract negotiations, silly me, I should have contracted for more money, was to restart doing this stuff. And so we do every other year Heart of the Matter, usually with 4 or 5 internationally well-known outside speakers. Dr. Hamid and Dr. El Kayem have been there every time we've done it. We usually have an anesthesiologist. We usually have someone MFM. We try to get nurses, doctors, pharmacists, candlestick makers, whoever has an interest in it to come. And I think I left it with 5 minutes for questions. All right, no questions. I bored the hell out of you. Good, I can go back up. More time in the spotlight.
Hi, thank you so much for that. I really appreciate the content. I really appreciate that you're here for 2 sessions, that we're having this great dialogue. My name is Missy Kotke. I'm at Emory and Grady, but I'm also the co-chair of the GAP-QC maternal arm. My co-chair is right here, and so I anticipate we're going to talk about maybe some of the same things. Would love to plug Georgia Perinatal Quality Collaborative booth is right outside that door. And so if folks are not familiar with the cardiac bundle, we're currently doing, 16 hospitals are currently participating. That's 16 out of the 75 in the state of Georgia. So if you aren't one of those, consider joining us. If you just want to grab some stuff, there are amazing resources out there. Specifically, you referenced screening. There are some cards that can help you. There's tools to put things in Epic. There are patient-facing tools. There are, for folks who are in smaller settings where you might not have a cardiologist immediately available, there's a card that can tell you, like, this person has this. This is what I should do in this moment. There's also an app that Dr. Bird's residents have put together. Just a ton of resources. So grateful for the conversation, but want to keep it going. If you don't have room in your bag, your swag bag is full. GAP-QC's website also has all of that stuff where you can order more and have it, delivered to your office or wherever is convenient for you. I think that's all I got. Thank you so much.
Oh, great. And that's great what we're doing. I mean, like I said, we're doing things to change those numbers. And, and giving guides to help people through things.
Yeah, cardiology is very close to my heart because my pacemaker is old enough to vote now. But what I'd like to bring up is that there is a very bright light shining in the near future for cardio obstetrics, and it has to deal with AI applications. And I'm sure you're aware of the ability now of programs that can basically diagnose PPCM from 1 lead and 12 lead EKGs. Those are out there now, and they're in the process of being FDA submitted and approved. That's going to be a game changer for places that don't have basically echocardiography readily at hand. The second thing is that there are also the increased ability to look at biomarkers early in pregnancy and even preconceptually, and to look at various factors, both genetic and circulating mRNAs, that are going to be the profile for people that can be accessed, identified, and addressed long before they develop problems. And that's coming to a neighborhood theater near you very, very soon.
Okay, thank you. Yeah, and as we talked about, the big thing is to identify who's at risk, get them evaluated or followed closer to try to prevent the unknowns, to prevent the surprises.
Teresa Bird here, co-chair with Dr. Kottke and work with GAP-QC. I wanted to first thank Dr. Padove. He is the reason that those aids that we have created exist. He was a part of the initial cardiac bundle committee that we had that created the acute care guide. So for those of you that don't know, a lot of the conditions, the WHO class 3 and 4, the most severe cardiac conditions, the patients at highest risk, if you know they have a heart lesion or a cardiovascular condition, we have created some cards that help you in the acute setting for some of you who don't have cardiology readily available, or your cardiology may not be as well versed in maternal physiology, to help you kind of acutely take care of a patient and not make her worse. It's kind of like a get out of jail free card. That's available here. Again, he helped develop that from the very beginning. We also have, if you guys are OBs in the room and you are not screening your patients for cardiac events in pregnancy using that CMQCC tool that he put up here today, if you are not screening your patients, you need to be. ACOG has endorsed that. There's also another version, but it includes very small things that you can do, looking at the heart rate, looking at the symptoms, and then potentially ordering an EKG and a BNP, and not a BMP, a BNP, as he said, and potentially a troponin and a chest x-ray. Those 4 things. If you are hearing about this for the first time, you really need to go by our table and look and see the tools that we have. We have the screening tools in a badge buddy so that you can just use it and look at it to say, should I order this on this patient? We're also coming out with some other things a little bit later, but if you are not screening, you really should be, and you need to go to our table to get your hospital involved so that screening can start to happen. The last thing I'll do is plug Dr. Hamid is coming to Northeast Georgia for grand rounds, specifically talking about the cardiovascular screening and the bundle. There is a grand rounds. We will be sending out information for you all to attend virtually or in person, so look for that coming from GAP-QC very soon. Thank you.
Just so you guys know, I think Dr. Mead, she is actually double boarded in cardiology and maternal fetal medicine.
Yeah, I guess triple boarded.
Or triple boarded, yeah.
And she has triplets, but they're older now.
They're older now, yeah.
She does things in 3s.
Thank you for the phenomenal talk. Really appreciate that. Again, my name is Ashley Teagues. I'm an REI in Atlanta at ACRM. As an REI, I think we struggle frequently with that question you kept mentioning of who should not get pregnant.
Yeah, that's a tough question.
It's really tough, and I think we, as a practice, try to be really individualized, but we send patients to, their specialists, their cardiologists a lot, and want to get some kind of clearance for pregnancy, but I know that's also a tricky thing to ask for. So any guidance or maybe more specifics you could shed on that question? Would you be using that WHO 3-4 criteria of, maybe just the 4 patients we really don't recommend getting pregnant, or what
Well, and lots of times, and what was mentioned by Dr. Rubin is it's, everybody thinks of IVF as being the older moms, but it really isn't necessarily. But the ones I see from y'all are the older moms. And it's almost like I'll put them on a stress test, even though there's no data. And if they do horrible as far as their exercise, I'm not expecting to find blocked arteries, but going to Dr. Pena's own sort of recommendations for them. I had a lady that did god awful, and I said, you know, most women 70 years old can do more than this, and pregnancy is going to be tough. And she decided not to go through with it because, you know, I told her to start walking, start losing weight, and rather than do that, she decided not to get pregnant. So, I mean, that's one of the things I do is I look at that. And certainly I add age because I showed you the 8-fold increased risk with over 40, you know, is significant. And heart attacks more likely occur over 3-fold over 40 in pregnancy. So I don't know that there's an easy answer other than functional status is helpful, because if they're having a hard time functional status without a baby, it's going to be harder when they have a baby. And at 40, it's not forgiving.
Yeah.
Did that help you? Is that
Certainly tricky.
I can talk
Yeah.
some more. I don't know.
Thank you.
Juan, do you have any input on that?
Yeah. So, you know, when I do preconception consults.
Yeah. And the World Health Organization's nice and discreet. I've got an interesting lady that's going to be fun, and I'll use her for some of these conferences. I saw her first time. She's about, I think, 12 weeks pregnant now. She was born with an ASD, VSD, mitral valve, probably a primum, got repaired, but also has malignant syncope with dysautonomia, and she's pregnant. And so that's going to be one that's not in that World Health Organization. I'll be seeing her quite frequently.
Yeah, that's,
and,
you know,
and that's what you see lots of times.
Yeah, I think to Dr. Tig's points, like there's some things that are not in these criteria. So.
And unfortunately, there's always the look. You know, you walk in and you see this patient, and you go, "Oh man, don't tell me you're pregnant." You know, so sorry about that.
No.
That's an aside. That'll probably get me in trouble, but what the hell. All right. Great. Thank you.